Good afternoon, everyone, and thank you, Daria, for the introduction. I'm Dr. Carmelo Crisafulli, specialist plastic surgeon working in Dubai since 9 years now. So let's start with the calf augmentation. Let's see how we should avoid the complication. We know that lately, in the last years, the calf augmentation took a lot of space in the plastic surgery. And of course, surgically speaking, the options are about the calf implants and the fat grafting. Calf augmentation with calf implants it's given by the insertion of the implants, which could be subfascial or submuscular implants. It's a stable and long-term procedure with give a long-term result. And fat grafting, of course, is the alternative we have that we combine always with liposuction. I would say fat grafting could be the safest way to do the augmentation in a surgical way. It's safe in terms of long-term result. It's safe in terms of procedure itself, if it's done in the operating theater, of course. But people now, they're asking always something which is done immediately in our office, something which gives an immediate result, something which doesn't give downtime. So they want to have everything immediately. They want to have everything in a safe way. And hyaluronic acid plays a huge role in that. I would say it's the only material we could safely inject into the calf to give some augmentation and definition of the shafts. So it's a minimum invasive procedure done in our office. It's quick. In 30 minutes, we achieve already an immediate result that the patient will appreciate even the weeks after with improvement of the volume. Has a very minimal downtime and having hyaluronic acid, a temporary nature. In case of complication, of course, we can immediately avoid to have more complication removing the filler with the hyaluronidase. There is no scar, just 1 or 2 entry point, and we will see now in the video how it will be. Quick intro about the anatomy. One major muscle, which is the triceps of Sura, made by the gastrocnemius lateral medial shaft, and the soleus, which is posterior and gives the posterior volume. In terms of vascularization, everything comes from the popliteal vein, popliteal artery. So we are talking about artery and vein, which are quite big. And that's why our entry point will never be from the popliteal groove, because it's the place where this artery and vein are coming from, but always from the side. On the lateral view of the calf, so we have the great saphenous vein, but it's anterior and medial, and medial, right? And so we don't touch this, we don't reach this area because we stay always on the top of the shaft of the gastrocnemius, because what we want to achieve is most of the time a lateral projection. Which are the best patients? A patient with not developed muscle, congenital small calves, and most of the time non responsive to exercise. We see amazing men with huge shoulder, big biceps, and small legs. That's why we play this game in order to give them also a nice definition and volumization of the calves. What is the patient expectation? Well, I made my theory, and I think that what women are asking most of the time is to have the same effect they get when they wear high heels. So definition of the medial shaft and the lateral shaft. Men, most of the time, ask the same, but also with posterior volume in order to show like a football player leg. So, of course, whenever we talk about augmentation of corporal district different from the buttocks, we always talk about MLF1. Why MLF1? Because it's still a not cross-linked acid with cross-linked acid, so we talk about the same material of MLF2. The injection area is always the hypodermis, so subcutaneous tissue, has a smaller particle size than the MLF2, which allows the filler to be more soft, I would say, and gives less deformity on the skin, also because we have to prevent to have any deformity. Injection can be done with a cannula of 22 or 18 gauge. I don't use needle. I use the needle only for the entry point and always use the 18 gauge cannula in my practice. So rheology of the filler. Lately, we are dipping into the rheology. What is the rheology? It's how a filler is made. I remember our friend Dr. Sundaram, she always make the example of the honey and the ketchup. Beautiful, amazing taste, both of them. But the honey for sure has a rheology which is higher than the ketchup because it's more cohesive, it's more elastic, it's more firm at the same time, and lasts longer, having a higher viscosity. And the hyaluronic acid, in this case for MLF1, gives also a less swelling factor. All our filler, MLF1, MLF2, they have also a lift capacity. Why? Because they maintain their shape after the injection. And this is given by the thixotropic technology that Bioscience put in its filler. Entry point, as I say, the main goal is to enhance the shape, to give more definition to the lateral medial shaft of the gastrocnemius. So we work with 2 entry points, always above the area we want to inject. Sometimes on taller patients, we can also have another entry point, which is lower and medial, in order to define also the lower contour of the shaft of the gastrocnemius. We see now a quick video about the procedure. So I will describe the video. First of all, it is very important to do the drawings while the patient is standing in front of you without shoes, without heels, without sneakers, without anything, just standing. When the patient is standing, we are able to draw the shaft of the gastrocnemius, asking the patient to step on the tiptoes in order to define the muscle area. This is my medial entry point to inject the gastrocnemius medial shaft. I use a plain lidocaine. I don't do any tumescent, I don't do anything, just injection of the entry point. It's a cutaneous injection, basically a dermal injection, in order to create already a hydrodissection. I inject 0.1 ml of lidocaine, no more, no less, it's more than enough. Pinching of the skin, why? Because the area of the calves doesn't have much fat. So it's quite easy whenever we go with the needle vertically perpendicular that we pinch the muscle. So we pinch the skin and we go obliquous in order to make the entry point. Injection technique is done always in the retrograde injection. And I show you now, I hope my camera has enough definition to show. I never go with a straight cannula. I usually bend the cannula a bit because it gives me more control and it's easier to inject. So this is how I use the cannula. Do not bend from the base because otherwise it will be locked. It will be closed and the filler will not come out. So it's a curve that we create in the middle of the cannula. We enter from our entry point, we lift the skin to be sure that the cannula is sliding on the top of the fascia on the subcutaneous tissue, and we do retrograde injection following the whole area we draw before. Do not freak out if there are small irregularities, because we have to do a massage anyway. So we keep the gauze with the disinfectant in the entry point, and with the other hand, with the dominant hand, we do a massage in order to distribute the filler evenly. Now, we have limit of amount we can inject. Of course, we cannot put 50 ml of filler in one side because we would compromise the vascularization. So it is important to stand to the indication that Bioscience gives to us, which is a maximum amount of 30 ml per leg in order to give a nice definition. Here is some result. As you can see here, I injected 2 syringes, so 20 ml on one side and 110 ml on the other side in order to compensate the asymmetry that the patient had. This is the front view, and here we have the back view, and you can see how nice and defined looks the shaft. It's exactly like the patient is wearing high heels. So there is the definition of the muscle. And be careful, try to keep in mind that it is a dynamic definition. The filler doesn't move, the filler doesn't migrate, it's following the movement of the muscle. So whenever the patient is walking, if you do a good massage, you don't see any deformity on the skin. Here another result, straight leg, 3 syringes each side, so 30 ml each leg. You can see here, I just create this slight curve in order to give the idea of having the calf. Or having the projection of the lateral medial shaft. Another problem that always happens is the asymmetry. No much result here, no a huge result, but if you pay attention to the left medial shaft of the gastrocnemius, it was looking shorter than the right one. With one syringe, I just make it longer in order to define both of them and give the symmetry to the patient. Lateral, posterior view and front view. Again. And when we do not inject, we talk about safety. Well, first of all, guys, we have to be very careful when we inject, when we do the injection. I'm an international trainer working with Bioscience now since 5 or 6 years, something like that. And the first thing I always say, do not stab the patient. I don't want to see, and we shouldn't do at all, this movement when we go under the skin. We use the cannula because the cannula has a blunt tip. If we push whenever we encounter an obstacle or whenever we had friction, we use the cannula as a needle, even if it's a thin gauge. So we have to be very careful and always find the right path and tilt the cannula if you find some obstacle. Sometimes also a massage, a superficial massage on the area where we want to inject, allow us to go even straight in the right position without touching the muscle or without going in different layers. So we do not inject when the patient has a vascular disease, because we don't want to compromise the vascularization. Patient with uncontrolled diabetes. Now, sometimes it's hard to find it out, but it is important. I always think, okay, cosmetic procedures are luxurious item, where I'm not talking about money, I'm talking about being healthy. So patients with uncontrolled diabetes, they have higher chance to have complication like infection, which actually, even if we are very clean, it can happen, because of course the diabetes can cause this problem. Whenever there is a skin infectious condition, a skin condition from psoriasis till infection, wounds, we don't treat the patient. Whenever a patient has previous treatment with permanent filler, we want to avoid. We don't want to wake the dog which is sleeping, because sometimes, whenever, even if our filler is very safe, whenever we inject in area where permanent filler is, we are increasing and we are giving more inflammation to the area. How to avoid complication? Of course, injecting the right layer is a must. We don't have to over-inject. The beautiful thing of the hyaluronic acid is that we can repeat the procedure. We don't have to be greedy, and we don't have to inject the maximum amount in one session. Patient can come back 3 weeks after, and we can still do some volume, give some volume. Ultrasound lately, they get a huge development in our procedure, and they can help a lot, mainly when you are starting to find the right layer, and also to have the idea, the perspective of where you are injecting. And apply gradual compression socks can help to reduce the inflammation and the swelling. Thank you very much, and I will see you soon with my next presentation.
Good afternoon, everybody. My name is Konstantin Frank, and I'm a plastic surgery resident. I spent 4.5 years at the University Hospital of Munich, where I did a lot of research about hyaluronic acid-based soft tissue fillers. And the last 2 years I spent in an aesthetic surgery fellowship with Dr. Kai in Marbella at Ocean Clinic. Now, here we do a lot of facial plastic surgery, but we also do a lot of body contouring. And what we did the last 2 years was also a tremendous amount of minimally invasive body treatments, body indications, and obviously MLF1 and MLF2 from Bioscience have been a big pillar of our minimally invasive buttock augmentations, hip dip augmentations, and obviously also calf augmentations. So I'm very happy to be here with you guys today, and I'm more than happy to speak a little bit about how we can make those treatments a little bit safer. I think it's fair to say that when it comes to body indications, we do have higher volumes, which automatically also pose a greater risk. And we do have different phases where we need to speak about safety in the treatment of buttocks and hip dips. Now, this presentation is called Key Players in a Safe Procedure. And I like this title very much because we actually do have different players when it comes to having the safest treatment possible when injecting buttocks and hip dips. Now, I chose this photo because I think it's very exemplary and imaginary of what we have to do. We have to protect our own head with a helmet like this, but we also need to take care of our patient, obviously. So there are two parts when it comes to buttock augmentation where we need to take care of our patient's health and well-being, and obviously our own well-being in terms also of legal medical aspects. And for me, being safe already starts before we actually inject. So for me, the first phase in the whole treatment cycle where we need to be safe is before the treatment. Now, you might ask yourself, how can we be safe before the treatment? We haven't even touched the patient. Well, it's quite simple. For me, conveying the right expectation to your patient is one of the uttermost things when it comes to treating the body with minimally invasive treatments. Many patients are used to, let's say, surgical results. Their own perception got distorted by social media. We as doctors also have created a little bit of a monster right there. So making our patients aware of what we can actually do with them using minimally invasive techniques is really important. So for me, this is one of the first steps when it comes to safety, having the right patient expectation. Then obviously also proper patient selection. Do a proper anamnesis. Look at previous surgeries. The patient will lie to you. You're trained for this, but be aware. Some patients won't tell you instantly that they had a BBL before, and then you might encounter much more fibrotic tissue than you might expect. Also, some patients already had previous complications with, for example, gluteal implants, and then are switching to explantation and want some more volume. Those are really important things for you to know, which you should know before the procedure and not during the procedure. Obviously, this goes without saying. Also ask them for any allergies or if they had any previous issues with fillers. Then obviously, very important, show before and after photos. This plays into this idea of how can we get the right patient expectation. Do meticulous before photos. This is really, really important to save yourself. If you do not have proper before photos, if there's any question about the outcome, if there's any question about potential complications, this is basically your best insurance. So do proper before photos, obviously also proper after photos. And then say no if necessary. There's no need to treat a patient if you do not feel like he's qualifying for the treatment. Say no before you have a patient. So this, for example, is a patient, typical patient that we encounter in our practice. And we have to tell this patient that we can work a little bit on the hip expansion right here. We can work on the hip tips, but he will not get a result like he would get if he would perform BBL, or if we would perform a BBL on him. Why? Because it's quite a big patient, high BMI. It's a little bit hard to see on the photo, but high BMI means it's also big buttock, which means that anything we add is in proportion to the result. And this is really important to highlight to the patient that you cannot get a complete surgical BBL result with this. Saves you a lot of trouble and makes your treatment safer. Now, then also speaking about safety, look at red flags. And one of those red flags is obviously body dysmorphic disorder, which is characterized by a present preoccupation with perceived flaws in physical appearance, which are unobservable or appear slight to others. I think we all know those patients. And it also has shifted in some patients, especially when it comes to body indications, into snapshot dysmorphia. So they use fillers online and then they want to kind of look like their filler, which drives them into our practice. And this is basically the algorithm. First you have the smiley, then they play around with the filters and they look like a flower smiley. Then they want to have the surgery to look like the flower smiley, but this is not always what you can do for them. So especially when it comes to minimally invasive treatments, be aware that there might be also a shifted perception, a distorted perception, and make sure that you do not treat those patients because it will become a nightmare for you. Now, during the treatment, obviously here we have several safety mechanisms in place. First of all, be clean. Even though it's a minimally invasive procedure, you're implanting a medical device. MLF1, MLF2 are medical devices, so be very, very clean. For me, being sterile is an absolute must. You can place the filler and the cannulas already on a sterile table. Let your nurse prepare this for you. That becomes much easier, and then perform a proper disinfection. We use propanol, which is Cutacept. We do not only disinfect the buttocks, but also the lumbar region and the thighs, obviously. They use a one-time usable tanga. We throw away this one-time usable tanga. You can buy them online, costs around 50 cents, but saves you a lot of trouble. And then obviously we place drapes in a square around the buttock, and we put an elongated gauze on top of the gluteal crease covering the tanga. We wear sterile gloves. This is really important. Do not use normal gloves, wear sterile gloves. If your nurse is assisting you and handing you over the fillers, also ask her to wear sterile gloves. Really important. Now, When it comes to the injection itself, you have to know your anatomy, know your superficial facial system, know that when you're superficial, there's a little bit more resistance, know when you're deeper, there's a little bit less resistance. And be aware of this interplay between superficial and deep fat. Be aware of the ligaments. Those ligaments are often posing a little bit more resistance, obviously at the superior gluteal adhesion, at the gluteal cleft adhesion, and the gluteal crease adhesion, and be aware of the veins. Don't go intramuscular. This goes without saying, but don't go intramuscular. Stay subcutaneously in the superficial fat, and definitely do not go below the muscle. Then after the treatment, obviously also really important to teach and educate your doctors on what to do after the treatments, and even more important, not only your doctors but also your patients. What should they not do after the treatment? This is a very classic question you get from many patients. Doc, am I allowed to do this and that? For me, it's a very simple rule. The rule is everything that starts with S and is fun is forbidden for 7 days. So obviously, sun, no sunbathing. It's not a good idea, not because it can cause some discoloration. This is obviously very rare and even not described in the literature, but you will get much more swelling, and we do not want to drive this inflammatory process of swelling. Then obviously also no sauna, placed in the same idea. I'm always very surprised how much people go into a sauna or a Turkish bath, but it's a regular question we get, and we do advise not to do it for 7 days. Then no sports for 7 days. Probably they're gonna go back to doing sports after 3 to 4 days, so I say 7. This is because patients probably are not always that compliant. After 3 to 4 days, it's probably fine. But again, we do not want too much movement. We also do not want any trauma to the injected gluteal region, and we do want to avoid this. Then obviously also no swimming. I don't know about the part of the world where you're from, but in our part, people go a lot to the beach. They have their own pools, they have their own jacuzzis. You still have a small open wound. If you use an 18 gauge cannula, it's actually not that swollen. We don't put a stitch on it. Obviously, it heals and it stops bleeding after a couple of seconds to minutes, but it's still a little opening. And then below, we do have a medical device. So make sure they do not go swimming or into the jacuzzi or whatever. And then wine doesn't start with S, but Sauvignon Blanc does. So also no alcohol. I try to keep it away from them, just for the simple reason that I don't think that it is a good idea to get drunk right after the treatment. You might fall or you might cause any other issues. So no alcohol for the treatment. Obviously also it increases the risk of hematoma, because what happens is vasodilation. You do not want vasodilation. This is really important. And then goes without saying, the last S that we forbid for a week is sexual intercourse, also for the risk of any contamination of this region. Now, obviously, they're probably not going to stick to it for 7 days, but I think it's always a little bit better to push forward how much they can do, and then they do it in the proper amount of time. So what do we do as well afterwards? We do a checkup after 24 hours by WhatsApp or email. Front desk does this to check with the patient. I want to see them latest after 7 days in the office, just to make sure that there's no inflammation, that everything is fine. And you have to know your adverse event management. This is really important. There will be complications. Everybody who has complications needs to know the adverse event management. There's a really good webinar we did with Bioscience in their online library. Check it out if you are not sure what to do in what case and what complication, but you need to know this by heart. And then obviously always run towards the complication. Do not run away from it. This is really important, because only when you catch it early enough, you can treat it easily. Now, without further ado, I'm heading over to the next speaker and very curious about the next insights. Thank you so much, and I'm gonna pick up again with you guys later on when we will speak about some scientific evidence we try to gather for you when it comes to buttock augmentations. Have a great lesson right now, and I see you guys later in a couple of minutes.
Hello everyone, it is my pleasure to be here. So today I want to start my talk with a basic reflection, telling you that if the great war catastrophers had been predicted, prevented, detecting certain aspects that could have somehow diminished, attenuated, or maybe prevented, detecting certain aspects that could have somehow, an event from happening, the story of the world definitely will have been changed in an incredible or transcendental way. So, well, today what I want to come and tell you is that safety is one of the most important aspects in any single procedures we perform, and with the use of special medical devices, which is one of them is the ultrasound, we can improve it more and more. So my name is Dr. Luis Fernando Reyes. I'm certified plastic surgeon from Colombia, Dubai. I'm an expert in ultrasonography, in plastic surgery, aesthetics, dermatologist. So I'm very proud, very happy to be here, and let's go with this. What's happening? Okay.
Here we go.
Hello everyone, here we are today. We're gonna do something really special today. Remember, patient safety first. Today we have a special case. We're gonna do a hyaluronic acid body contouring procedure guide with ultrasound. So for safety purposes, we're gonna use ultrasonography for our patient to do our hyaluronic acid procedure. So let's go and let's see what's happening.
Here we go.
Money, money, making crap for money. Money, and money, money, making crap for money. Money, yeah. 当他们都在说有钱才能做自我，掉入消费主义陷阱，花钱不思索，被思想的艺术品多得我快数不清，有垃圾点缀的歌我简直都不想听，自卑敏感也会围绕在你周围，渴望财富不断在你心中积累，幻想买些奢侈品来塞进包包，你流的那些口水简直就像黄河滔滔，想让我帮。
Okay, so dear colleagues and friends, it is time to introduce within the medical, surgical, or non-surgical arsenal that we have in our daily practice, a tool that allows us not only to perform a specific type of procedure, but also to make a diagnostic and therapeutic approach. So using the ultrasound as an integral part of procedures, and the most important thing, remember, patient safety first. So let's start with basics in ultrasonography. This is of course a big word, but I need you to understand some basics to have an idea, for sure. So ultrasound, what is ultrasound? Ultrasound is a transformation of the mechanical energy of high frequency sound waves. And we use these acoustic properties of the matter to see in real time the anatomy of our patients. So in ultrasound, one cycle is the amount of times that goes and comes back the acoustic wave in a specific period of time. So when the ultrasound needs to go deeper, it's going to last more going and coming back. So in those terms, it is going to be less time. So this is called low frequency. In the opposite case, if we need to see something more superficial, the wave is going to go and back more times, so more often, and this is called high frequency. So for us, it's really important that you know which ultrasound to use according to the areas that you are going to work more often and how deep or superficial you are. So we're gonna talk something else about semiology. Remember that we are not gonna talk anymore about black and white and gray colors. So from now on, we're going to talk in these terms more acutely in ultrasonography. So that means that everything we see in white is going to be hyperechoic, right? So you're seeing right now the hyperechoic. Everything we see in gray color is hypoechoic, right? And everything we see, so this is hyperechoic, okay, hypoechoic, and this is anechoic, everything we see in black, right? So anatomy always is the basics of all in our field. So it is completely necessary to know when we work at the gluteal area. So we need to be very cautious with the arteries, veins, nerves. So that is completely necessary to know where we. So ultrasound is completely dynamic, more than static. That means that we prefer to see everything in real time, like you are seeing right now. So let me show you. Perfect. So speaking a little bit about ultrasound guide hyaluronic acid injection, the first thing we must to understand is that we are going to identify the same planes that we already know from the anatomical point of view. In that order of ideas, so what we're gonna do is a transfer of anatomy to a sonoanatomical view in real time. So we're seeing right now the superficial fat layer, the deep fat layer, and the muscle. So as a part of the use of hyaluronic acid in body contouring procedures and corrections, the use of ultrasound becomes necessary. So with the aim of having a better visualization of the planes, a better visualization of the cannula and the site where you're gonna inject. So that's why this talk was born: safety and precision. So, and that's our goal. That's the goal. That's the idea that we all begin to identify several interesting things. Identify your muscle plane, fat layers, and where is our hyaluronic acid, right? And if we manage to identify these structures very well, with the subsequent training, of course, so we will develop the skills to be able to find where a cannula is and identify the different planes in the exact way and the time to perform the better injection. So this is really important to do everything with ultrasound because of the perforated vessels to avoid complications. That is completely necessary. So sometimes we hear that ultrasound is very complex. That is, it has many buttons. That is a dependent operator. That is difficult to perform, or only a radiologist can perform it. Well, part of it, it's true, but there's also some important things to highlight. So you will develop skills to be able to recognize all the tissues and get more out of all the devices, the transducers, and the equipment. So although the interest of this talk is that you open your minds to get the great perspective that ultrasound can provide us, okay? So in this time we can see how the transducer, how do we use the transducer in the application of the hyaluronic acid. So how can we see the cannula? How can we see the needle? It's completely necessary. So this is the way that we can see the cannula and the needle. There's a couple of maneuvers that we use in ultrasonography applied to cosmetic procedures. And we're gonna see here. So if you didn't see the cannula, now you can see the cannula in this yellow color. So here we are. So these are the different maneuvers that we use. The first one is tilt. When we push the needle or the cannula to see exactly where are we located. The second one and you can see the movement of the cannula. Perfect. So the next one is, okay, we're gonna, I don't know what's happening with the video, it's okay. So heels in, so it's the second one. We missed this one, there you go. So we can move our transducer to look for the body of the cannula, right? The next maneuver that we use is rotation. So in rotation, we change the plane of the transducer to see exactly where are we located with the cannula, and if we're well located in the place in the layer, the fat layer that we're gonna place the hyaluronic acid. Perfect. And the fourth one maneuver is translation. So we move the transducer. I don't know what happened with the video, but okay. So we move in the same plane. We do not rotate the transducer. We just put it on plane according to the cannula, and we make soft movements with the cannula, right? With the transducer above the cannula. So for these reasons, it's completely important to know how to understand, practice, and train in this type of process under the ultrasound vision. So another thing that I'm telling you is that ultrasound is not going only to help you with the clinical practice. No, ultrasound has a basics in the legal part. So we are going to provide you all the tools to protect yourself during some adverse event that once does not happen or some kind of complication. So the idea is we can use the ultrasound to support us in our private or in different practice. So after the procedure, we can see, this is the way that we can see the hyaluronic acid, and we can see the vacuole. This is the shape, anechoic shape, perfectly regular, well definition. So, dear colleagues, that's it. This is the new stethoscope of the doctor. This is an extension of what we all already know clinically, and we already clinically manage. So please remember safety, patient safety first. Thank you so much for your attention. I'm really happy, really proud to be here with you.
So I'm back. Well, nice picture. How we can be safe when we do a body filler procedure. First of all, it's very important to do a proper patient assessment. Not all the patients are the same. Some of them, they want something that we cannot do, or vice versa. It is very important to check the body shape of the patient and be sure that we can give a result. And like Konstantin said before, we have to say no sometimes. So here we can see the classic 4 shapes of the buttocks. We have the square or H shape, round or O shape, heart, A shape, and inverted, and V shape. And what the patient want? None of them. They want the peach. So let's see how we can achieve that, and let's see how we can satisfy our patient. Before doing any procedure, like all our colleagues said so far, anatomy is a must. We have to know the anatomical region we are treating. We have to understand where are the muscle, where are the retaining ligament, where are the tendons, why the skin is made by different layers. And we have mainly to understand also that we have to inject in the right layer. Now, Bioscience gave us two beautiful products, which are the MLF1 and MLF2. MLF1 has a smaller particle size, as MLF2 is quite bigger, and actually MLF1 is used for hands, for hip dips correction, concave deformity, calves volumization, while MLF2 is mainly for buttocks augmentation and hip dips correction. The good thing is that we have to learn how to mix the two products. Our skin is made by superficial fat layer, superficial fascia, deep fat layer, deep fascia. MLF2 being bigger is better to be placed in the middle of the deep fat layer in order to give the support to the skin and having the support of the fascia as well. While MLF1, like in case of hip dips correction, is the one used more superficially in order to give a smoother surface of the skin. Like before, the marking, the drawings have to be done in a standing position, no shoes. Check always the shoulders. It's normal. All of us, we have an asymmetry. All of us, we have a buroscoliosis. The desk, the computer, when we study at the university. So we have to understand that it's not possible always to do, okay, I inject 5 syringes one side and 5 syringes on the other side. Sometimes we need 6 and 4. Sometimes we need 10 and 3. So it is very important to assess the patient and check if there is an asymmetry and do the drawings in the patient standing position. Anatomy and layer of injection. I spoke already about superficial fat layer, deep fat layer, and in between there is the superficial fascia, and then underneath, under the deep fat layer, we have the muscle with the muscular fascia. Ultrasound helps you a lot. And as you can see, with the big slice of the muscle here, we are just 5 centimeters deep. So knowing the layers is very important. Here we see how the layers change when we do the injection. We see the dermis is a very superficial layer. I inject the filler. I distribute MLF1 on the superficial fat, MLF2 on the deep fat. And with this vision, you can see how is very well defined the deep fascia with the superficial fascia. And this gives the continuity and the smoothness of the skin. We gotta be careful to not inject a big bolus and then don't do the massage, because this can cause complication, as we can see quite soon. Patient preparation under aseptic condition. Now, I agree 100% what Dr. Frank said before. Everything sterile, everything clean, yes, but let's go back to the reason why the patient they want to do butt filler. Because it's something that can be done immediately, something that doesn't need recovery, something that doesn't need a huge commitment by the patient. So we have to create as much aseptic condition before doing the procedure, but we cannot inject always in the operating theater. So it is very important that we pay attention how to be clean. Disinfection of the skin, sterile gloves, and disinfection of the surrounding area before putting the drapes. So injection technique, let's see this video. I will comment a few spots of this video. So as I said, of course, we need sterile gloves. We disinfect the whole area. I already disinfected before under the drapes, before applying the drapes. I prefer to use chlorhexidine because it's a non-alcoholic surgical disinfectant, which works quite well. I did my drawings before. I do injection of local anesthesia, same technique as for the calf. So it's a small injection, 0.1 on the dermis, basically creating an hydrodissection. Why here the hydrodissection is very important? Because in this way, when we do the entry point with our needle, we are sure, if we enter just 2 millimeters, when we enter with the cannula, we are touching immediately the superficial fascia. So we know already that we are on the superficial fat layer. If we want to go deep, we just incline the cannula and we go on the deep fat layer. I'll show you now, continuing on this video. I don't do personally tumescence. I don't distribute anesthesia around the area because so far I never had this kind of problem. I do my entry point perpendicular to the skin, just few millimeters inside, 18 gauge needle, the pink one. Do not rotate, do not tilt the needle. Why? Because we are using an 18 gauge, which is quite big, it's around 1 millimeter. And the tip of the needle, it's triangular. So if we rotate and we are into the dermis, we scratch the area and we can leave a small mark. I start my injection with the cannula. As I said before, I prefer to use a 10 centimeter cannula. As you can see, I hope you can see here in the video. Let's see if I can show you better. There are tags on the cannula. Its tag is 1 centimeter, which give us the idea where we are. And do not forget always to mark the exit point of the filler. Some of the cannula, they have an arrow on the base. If like this one, you don't have it, just mark with the white skin marker the corresponding point of the exit of the cannula. Why this is important? Because we have to inject always with this point upwards. I'm touching now the superficial fascia. You can see there is a depression of the skin. I want to go on the deep fat layer, so I pinch the skin, I tilt my cannula, and I go on the deep fat layer, and as you can see here, there is no more pinching of the surface of the skin. Means we are below the superficial fascia. You don't need to go deeper. You don't have to touch the muscle. The patient feels pain because we are touching the muscle, because we are too superficial, or because there is a lot of fibrotic tissue. As you can see, I did a small massage with a smooth movement of the cannula and retrograde injection. I don't do this. We are not doing a lipofilling. A continuous pressure on the cannula and movement with the other hand. In this way, the cannula will slide easily through the fat fibers of the fibrotic fiber. It's not complicated at all. I see the area where I want to inject. I put my finger. I want to feel the filler coming out under my hand. And in this way, I distribute the product all over the area. In this patient, I plan to inject 10 syringes, 5 each side. Usually, the first 2 syringes I use to create a scaffold. So I go on the deep fat layer. I distribute with retrograde radial injection the filler on the deep fat layer in order to create a base where I can build my volume. I'm going again with the second syringe. You can see it's going very smooth. Of course, she is a perfect candidate. I'm pushing to fill my cannula and to see where actually I am. And now I build with retrograde or microbolus injection my volume. So slow movement, don't be aggressive. We don't want the patient to bleed. If we find an obstacle, just tilt the cannula, go back and try to go forward again. Do not push too much, because that obstacle could be even a vein, could be a perforator artery. And if it's a perforator artery, we can break it. And of course, we can cause complication. Let's go ahead. So as you can see here, what I was meaning before, it's about the layers of the skin. We have 3 different conditions. Healthy patient, maybe my daughter 2 years and a half, she has a healthy skin. But most of the time we have patients with cellulite or laxity of the skin. So in this case, let's see if the injection, okay, it's starting. In this case, we have to distribute the filler, MLF1 and MLF2, in the 2 different layers in order to release the tension of the fibrotic septum between the dermis and the superficial fascia, and give the volume, the deep volume, in order to create a smoothness of the skin. Keep always in mind that also the being hyaluronic acid is improving the skin quality, because there is a water recalling, so a moisturization of the skin. And this is helping also on the cellulitis of the patient. You will see this result 3 weeks after. The patient is super happy also with the skin texture. In case of laxity, which is a borderline patient candidate for body filler, we have to inject on both layers, like I said before, not to exceed, but do several injections in order to build gradually the volume without giving any complication. I always do final touch-up while the patient is in a standing position. You can see here in the video, always trying to be as much clean as possible. I always have a gauze with disinfectant in my hands to clean the area. So small touch-up, usually with MLF1 and always retrograde or microbolus. And after we finish the touch-up in a standing position, massage is a must. Now, volume and right injection technique. As you can see here, there is an even distribution. I don't know if you can see my mouse, but the first small bolus is on the deep fat layer, and then there are two other bolus on the superficial fat layer. So this is the first phase of the injection. Then I do a small massage, and with the massage, I get this result, which is a distribution of quite even of the filler, but this is still not enough. This is what I want to achieve. A filler which is spread all over the tissue. You can see you didn't lose any volume. It's always 4 centimeters, but you reduce a lot the complication. Because if you have a granuloma, if you have a lump, the patient can have complications. So the filler has to be distributed evenly on the area we want to volumize. There is here a nice video. Wait, I will play it. Nice video, which is showing with the Clarius, this ultrasound I use, how the layers are respected with the filler injection. You will see soon, I hope. There will be different color and will be the lower part, which is the muscle. And then it will start to be superficial fat layer and lower and deep fat layer. Let's see if it's going. No, unfortunately, it didn't go through. Anyway, I will be more than happy to share all this picture with you guys. These are a few results. We can have volumization, lateral volumization and projection, correction of the hip tips, correction of hip tips and volumization, and the famous pitch shape with the patient who has already a nice result, a nice shape, but she wants to improve on the trochanteric region. And then, guys, these are case limits. I always say do not treat this, but I believe I have a bit of experience. This is not because I want to show off with my practice. This is to show you that if you are planning to do a proper injection, if you are planning several sessions, this is a result that can be easily achieved. Even in patients who are not good candidates, being safe and being cautious with the injection will give this result. So I will thank you, everyone, and I believe I will continue soon with my other presentation. You see, Constantine says something very, very true. We have to run forward the complication. So we have to attack the complication before becoming more complicated. So if a patient has already complication, of course, we don't treat the patient in the first instance, but if the complication comes after we did our procedure, we have to treat the complication. Now, let's see with the slide, with my presentation, which kind of complication we can have, because we can have immediate and delayed complication. First of all, once again, introduction about the product. Biphasic filler, MLF1, MLF2, we give volume, reduce swelling factor, reduce cohesivity, high elastic response, firmness, and lasting of the filler up to 2 years, 1 year and a half. Immediate adverse reaction, reddening, swelling, and mild pain. This is something that happens. Keep in mind the patient will have this problem. You will face this. When I started, some patients were calling me at night saying, I cannot sleep, I have pain. Okay, this is normal. We are injecting a foreign body, so we are creating an inflammation. I just give to the patient some anti-inflammatory like Panadol, paracetamol, just for instance, 1 gram before going to sleep, and the patient don't complain anymore. Ice pack can be applied. Just be careful when you apply the ice pack. Don't have a direct contact with the skin, because having an inflammation causes the patient not to feel the cold of the eye. So at the end, you can have discoloration, or sometimes discoloration, or sometimes also burns because of the eyes. Contour irregularity. Well, this is because we didn't inject properly. So the filler is not placed in the right layer or not in the right anatomical region. I had patient coming to me after injection with other colleague, and the filler was injected on the lower back, not even on the buttocks area. And of course, this is causing a problem. So we have to massage well if this is happening to us immediately after the injection, and avoid to do big bolus. In other immediate adverse reaction, bleeding and hematoma, it can happen sometimes also because with the entry point, we hit a small vein and the patient bleed. But most of the time it happens because we are aggressive with the injection. So avoid aggressive injection. How we solve it? Just a compression and a control check if there is still bleeding or not. Hypersensitivity reaction, filler intolerance. We do corticosteroids and hyaluronidase to melt the filler. It can happen. Some patients, they don't tolerate the filler at all. Tyndall effect, superficial injection of big bolus. We have to massage, and if the whitening stays, we have to use hyaluronidase to melt the filler, which is superficial. Ischemic complication, I never wish to anyone having a ischemic complication. Most of the time it happens because we are injecting very deep, so under the muscles, or intravascular injection. Now, guys, when we inject with the cannula, and if we inject in a proper way, it's almost impossible to go intravascular. I had patient coming to me with filler under the muscle. I don't know how could happen, because if I touch the muscle, probably because I don't do general anesthesia on the area, the patient jump because of the pain. So these are the cause of the ischemic complication. What we have to do, immediate dissolving, most probably, and better to do ultrasound guided, antibiotics, corticosteroids, and ice pack. Delayed side effect, bacterial infection. Yes, it is always doctor's fault. If a patient has an infection, it happens in our clinic. It doesn't happen out of the clinic. Why? Because the patient usually stays with us 10-15 minutes to check everything is fine, because we should use a sterile plaster, because we should apply antibiotic cream. So I always say this is our fault, not the patient's fault. I would say 99% of the time. We do antibiotics immediately. We prescribe immediate antibiotics, anti-inflammatory, hyaluronidase. If it's continuous, biopsy, culture, and antibiogram to see which one is the right antibiotic. Nodules, lumps, it comes always because there are big bolus injected in the wrong layer most of the time, and wrong patient selection. So we have to be careful when the patient has bulky skin. Bulky skin means fibrotic tissue. Most of the time, patient who had BBL before, patient who had implants and removal of the implants, patient who has fibrotic cellulitis, or patient who has been treated with other fillers in the past. So whenever we have bulky skin, injection has to be done only exclusively on the deep fat layer, not superficial. If the patient has pain, massage, anti-inflammatory, and hyaluronidase to dissolve the filler. No pain, just massage and hyaluronidase. Biofilm formation, it comes, of course, after infection. We do an ultrasound guide biopsy, a culture, and antibiogram. Granuloma, it is an excessive immune response to the infected nodules. Sometimes we have granuloma not infected as well. It happens because we injected amount of filler in a small area, which is too much. So we did big bolus, and this can cause the granuloma because it creates a big inflammation. So we do ultrasound guide injection on hyaluronidase because we have to be precise on the core of the granuloma to remove the filler, to dissolve the filler. Or sometimes, if it's a late granuloma and maybe we don't have much hyaluronic acid left but only fibrotic tissue, collagenase can work, and of course antibiotic, biopsy, culture, and antibiogram in case of infection. Migration of the filler, it's our fault. Wrong technique, wrong injection layer, excess amount of product. We do an injection of hyaluronidase ultrasound guide. I would like to add something about what Konstantin said before, the 7S. I would add two more, which are related to the last one he said. I always tell to the patient, and I work in Dubai, so a very conservative environment, do not squeeze the area, do not slap the area, because this can increase the inflammation and cause infection, and cause complication like migration of the filler. These are recurring inflammation, which most of the time is given because there is intolerance to the product or wrong usage of the product, means in superficial injection of MLF2, for example. And lately, we saw patients after COVID infection or after COVID vaccine who are developing this kind of recurring inflammation quite often, not only for the body filler, but also for the face filler. Now, it happens quite a few times, patient after even a viral infection like flu, like other problem, having this kind of complication here. What we do is an anti-inflammatory, and of course, we check if we have to melt the filler or not. There are a few scientific works with chronic inflammation or delayed inflammation of filler after COVID vaccine. You can check in literature. Corticosteroids has to be used, and hyaluronidase if it's necessary. And this is a necrosis of the superficial. This is a paniculopathy, actually, but I will put this picture because this is a patient who did the permanent filler before, and someone injected also the hyaluronic acid on the top. So in this case, the patient is developing a liponecrosis. This is a paniculopathy, which cannot be solved easily. Patient has to be under antibiotics most of the time, IV treatment 3 times a day, anti-inflammatory in higher dosage, and debridement if there is, of course, a superficial necrosis of the skin. Sharing the experience is a must. We create a net with Bioscience, with all our colleagues, all the conference we do from IMCAS, from the other training, our academy that we do, trying to teach to our colleagues. We support the physicians who are asking requested for help whenever we have complication. But it is important to share the complication, do not hide. It's normal to have complication, but only sharing the experience can help to improve and develop guidelines to ensure the safety and minimize this kind of complication to come further. Bioscience has a nice form that can be filled by the physician and sent to our medical committee, which analyze the problem and gives the most of the time solution or suggestion to the doctor how to work to solve the complication.
Thank you so much, Dr. Crisafulli, for your very insightful presentation on how to perform safe gluteal augmentations in a very practical setting. We're now going to continue with a little bit more theoretical topic, and this theoretical topic is obviously the science and the data behind buttock augmentation and hip dip augmentation using higher corp. What we did was an investigator-initiated trial together with Bioscience, and we treated more than 60 patients and tried to gather as much data as possible to give you a very scientific base when you will also kind of argue with your patients why buttock augmentations and hip dip expansions are actually safe. Let's have a quick look at the study that we did. It was obviously a prospective study, and it was built by initiating with the screening. Obviously, there were several inclusion and exclusion criteria. However, I want to add at this point that we try to keep it as realistic as possible. So obviously, the perfect scenario would have been patients with low BMI, as you get, let's say, the most dramatic results in those patients. But we actually wanted a very realistic point of view right here. So the inclusion and exclusion criteria were not very narrow. We then started with the first treatment. The treatment included injection of up to 60 cc of MLF2 into either the hip dips or into the buttock. And the patients were then screened or seen after 4 weeks. This was the first follow-up meeting, and there was the chance of an optional touch-up. So we could inject up to 60 cc again into each patient on each side, giving us a total of 250 cc overall when it came to augmenting the buttocks. Now, what did we do? We always looked at the global aesthetic improvement, which was done by an observer and by an investigator. We then also performed some measurements, and those measurements included the hip circumference, the waist circumference, and the circumference at the biggest buttock projection. This was done manually. We then also moved into 3-dimensional photography. We used the Vectra system right there, and we obviously performed standardized 2-dimensional photography. Then one very important thing that we also did was ultrasound assessment. So we actually looked how the product is spreading, either if we inject it as a thread or as a bolus. Now, after 24 weeks, which is 6 months, patients were allowed to come back, and we again did the measurements, the 3D and 2D photography, and obviously also the ultrasound and checking for any adverse events. At this point, we have completed the follow-up for all 60 patients, and let's say about 25% do already have their 6-month follow-up. We're really happy with the results, and I want to show you some data. What were the objectives that we looked into? the primary objective was to assess the proportion of responders. A responder is a patient which was considered as responding to the treatment. So when we had to define this response, it was obviously an increase of greater or equal to 1 point increase on the 5-point global aesthetic improvement scale after 24 weeks. Secondary endpoints was the Guy's improvement for buttock projection and hip dip depression after 4, 52 and 104 weeks, which is a total of 2 years. And then obviously we also looked at the vertical and the horizontal spread of the bolus and the threads in the gluteal tissue using ultrasound. Last but not least, we looked at the hip to waist ratio after 4, 24, 52 and 104 weeks using three-dimensional surface imaging, but also classical measurements. And lastly, also looking at the gluteus circumference at maximum projection. Now, what are the results so far of those that underwent already the 4-week assessment? I can tell you that 100% of the subjects had an improvement of greater or 1 point on the 5-point global aesthetic improvement scale on buttock projection. We had 100% of the subjects also with an improvement of greater or equal to 1 point on the 5-point global aesthetic improvement scale for hip dips. So in all of the patients we treated, we got an improved result. Now let's look at how much this improvement actually was. In total, 15 subjects showed very much improved result, 9 for the treatment of hip dips, 6 for the treatment of buttock projection. 32 showed a much improved result, where 17 were treated for hip dips and 15 for buttock projection. And last but not least, 30 subjects showed an improved result. Of those were 7 treated for hip dip depression and 6 for buttock projection. Let's look a little bit at the measurements. The mean change in buttock projection after 4 weeks was 2.13 plus minus 2.04 centimeters, with no statistic significant difference. Now, the mean change in waist was also not statistically significant, which is important because it shows that both waist and hip circumference did not alter too much, which means that actually we did not have much fluctuations in the actual body composition of the patients. The mean hip to waist ratio at baseline was 1.3, and we went to mean hip to waist ratio after 4 weeks to 1.33, also not statistically significant. Now, the change in mean vertical bolus extent at the buttock was 3.27 centimeters. This is really interesting because we can see that the change in mean horizontal bolus extent at buttocks was minus 2.4 centimeters. I will show you this later on to make a little bit more sense out of it. Just keep in mind that the vertical extent increased while the horizontal extent decreased. Now, the change in mean vertical bolus extent at hip dips was 5.27 in the beginning, and then the change in mean horizontal extent at hip dips was minus 4.4 millimeters. Now, what we conclude from this is that the boluses remain in their shape better at the buttock, while there seems to be a shift to a more vertical shaped bolus, i.e. thread-like shape, when injected in the hip dips. You can see it a little bit like this. In the hip dips, we become a little bit more spherical, which makes sense because we do have a very parallel arrangement. In the buttock region, however, the boluses actually kept their shape quite well. And one reason for this is obviously the presence of the superficial facial system. So you can see that we can fill kind of within those septi, and the filler is strong enough also to withstand the pressure of the whole body resting on the buttocks, and it still allows for enough projection. This is one of the main reasons probably why even after 6 months we already have the first patients incoming with very satisfying results. Now, the adverse events that we found were obviously pain. Immediately after injection, the pain was 3.27 plus minus 0.4, and after 15 minutes, 2.25 plus minus 1.3 on a 0 to 10 scale. Now, what is really important is to say that we didn't use local anesthesia. We just used some ultracaine for the insertion point, but there was no infiltration of tumescent solution whatsoever, just to keep the study kind of as unbiased as possible. There was a significantly inverse correlation between BMI and VAS 15 minutes after injection, which showed that the bigger the patients were, the less pain they actually had, which makes sense. Now, here is a little photo of a bolus after 4 weeks. On the left side, you can see that it is still quite spherical, while the threads were still threads after 4 weeks. Here, a patient example before and after with vector 3D photography, before and after with three-dimensional reconstruction, and then also in the morph picture. You can see quite nicely here how we worked on the hip dips, how we got a really great shape on both sides, how we increased also the circumference by 1.1 inch with 120 cc on each side. And here also patient which is a little bit harder to treat. You can see this massive hip dip right here, and I think for a minimally invasive solution we did quite a nice job here. Now, this concludes my presentation about Ultrabud study. We're very keen and happy to present more results in the upcoming months. We will keep you posted how the patients are doing after 6 months. When we have all 60 of them coming in, we'll post you how they are doing after 1 and 2 years. And we're very happy that we have the chance to collaborate with Bioscience right here to create a little bit more of a scientific background for gluteal augmentation using HA-based soft tissue fillers. Thank you so much for staying with me on this obviously a little bit more theoretical topic, but I think it gives you really good confidence to tell your patients that in the study 100% of the subjects actually saw an improvement for either hip dip or buttock projection. Without further ado, I want to thank you. I will join the Q&A session later on for any questions in regards to the study, and we'll hand over to the next speaker. Thank you so much.
So hands rejuvenation, why we do the hands rejuvenation, why patients are asking for filler on the hands? Well, first of all, because we treat most of the time elderly hands. So the patient want to have an improvement of the skin texture, the patient want to have an improvement of the quality of the skin. So poor skin quality with pigmentation, loose skin, visible vein and tendons on the dorsum, and absence of subcutaneous fat tissue. Quick note about the entry point. Now the right X is not in the right position. Entry point, I hope my camera is showing that, are basically on the entry point that we were using during our residency for the arthroscopy of the wrist, which are the radiocarpal joint and ulnocarpal joint. These are two safe places because you don't have important structure underneath. So it's very easy, just ask the patient to bend the wrist, I hope you can see, and check where is the groove. Then with the flat hand, check which one of the two grooves you select doesn't have any vein underneath. We start with the video. Wait, here is the video. Okay, so I will try to be quick about the video. Maybe I can put it a bit further. Don't judge my hair, it was before the hair transplant, huh, guys? But no. So I'll go a bit faster here because we don't have much time. I want to keep some question and answer. So we can see here a patient with elderly hands. I'm checking the area to inject before doing the injection. I draw my entry point. I always do a local anesthesia with lidocaine. Let's go quick. So I mark my entry point, I check where is the groove, I literally can put the finger inside, so it's a safe place to do injection. I always use a cannula, I don't go with the needle, and in this case I use a 7 centimeter cannula, 22 gauge. So I disinfect once again the whole hand. Let's go faster. I do again the marking of the entry point, and I do my local anesthesia. 0.1 of plain lidocaine. On the limbs, on the extremity, we use always plain lidocaine. We don't need any adrenaline. We pinch the skin, we lift the skin, we inject our anesthesia, and we do the same maneuver for the entry point with the needle. As you can see, I'm injecting just 0.1. Same concept, hydrodissection, in order to be sure to be immediately into the right plane. Entry point with the needle is a 22 gauge needle. There is no bleeding. I put the hands under tension. We need the skin to be tanned. In this way, you see that the cannula is sliding very, very nicely under the skin. Now, you will encounter always some vein during your path. Now, it is important to not force, because if we break accidentally a vein, which can happen, we have to stop the injection. So we have to postpone the procedure after a few days. But when you encounter a vein, do not push further. Just twist and tilt a bit the cannula in order to go on the top or on the bottom. So always tension of the skin, retrograde injection. We distribute the filler evenly, creating several tunnels under the skin. And then at the end, we will do a proper massage in order to distribute the filler till the nock, so till the interdigital space. The limit of injection usually is 2.5 ml each hand. So using one syringe of MLF1 will allow us to do even a second treatment after 3 to 4 weeks. And after the injection, we disinfect again the entry point. We cover it with the sterile gauze with the chlorhexidine or disinfectant, anyone you use, and we do a proper massage. Massage can be done also with some antibiotic ointment, which allow us to slide on the skin and reduce the trauma to the patient. The result immediately after, of course, improves after a few weeks, because we have to respect the skin turnover and we will have a proper nice moisturization of the skin. Whenever there is a skin condition, so psoriasis, hyperkeratosis, precancerous lesion, Raynaud syndrome, or arthritis, we don't treat the patient, because with the inflammation given by the filler injection, we can develop the crisis of arthritis. Patient had previous treatment with permanent filler or semi-permanent filler, we don't inject the hyaluronic acid. And something which is not written here, but it's very, very important, because I saw complication because of this. Explain to the patient that for the first 24 hours, if they have any pet like dogs or cat, they don't have to touch them. Because the first thing this dog or this cat do is to lick the area, removing the fibrin lead that create on the entry point, and in their saliva there are enzymes and bacteria which can cause very bad infection. Complications are the same for everything. All the complications related to the filler are more or less the same. Of course, can be more or less important according to the area we are treating or to how much filler we inject. The way to treat the complication is the same mentioned before for the buttocks. We can have inflammation, reddening, swelling. These are normal, I would say, outcome after the injection. What we have to really avoid are the ischemic complication and the infection. This is a must, because when we have an ischemic complication, if we don't treat them immediately and we try to save time and have avoid the necrosis, then it's a permanent lesion that we leave to the patient. Thank you very much. I hope it was an interesting webinar so far, and hopefully we will have soon question and answer. Thank you. We are working with Bioscience to put down some protocol and to make guidelines to avoid to have complications because of the over-injection. Now, for the calves, it's very, very, very associated to the patient. It depends how the patient is. It depends how the skin is. It depends by the elasticity. More or less, we would stay around 5 syringes max each side, which is 50 ml. And we have really to avoid the over-injection, mainly because we have to avoid the compartmental syndrome. If we add too much filler, we create a compression of the vascular system, and the patient can have very bad complication. So the limit for now we are established is 50 ml. You see from the previous before and after, there are patients that injected 30 on one side and 10 on the other one, but more or less we are on 5 syringes. It is very important to start always from the hip dips correction. There is no point to give volume or projection to the posterior part of the buttocks if we don't feel the hip dips. The limit that we plan with Bioscience is 15 syringes in total. I am honest myself, I had many patients, I injected 10 syringes each side. It depends how big is the area, but most important is to distribute the filler and to massage properly, because if we do just bolus injection, of course, you will reach the limit after 10 syringes for sure. So you cannot go over. It is also very important to stop sometimes the injection. When you start feeling the skin becoming harder, means that there is too much pressure from the injection of the filler, we don't have to go further. So we stop our injection and we tell the patient, I will see you back in 3 weeks. Limit for our guideline is 15 syringes. So it's 7.5 each side. It can be 7, 8, it could be 16. It depends how big is the area, just to not over-inject.
100%. I think it's really important that we're aware that we are injecting in a certain kind of matrix, and you can't overfill this matrix. This is a concept that you need to adhere to when you do lipofilling, obviously, in all regions of the body, not only the gluteal region, but obviously also hands, obviously face. You're grafting either fat or, in our case, hyaluronic acid into an existing matrix. And if you put too much pressure within this matrix, you will end up with complications. One of the less severe complications, obviously, then is going to be hematoma. It's not only hematoma because you really destroy any kind of vascular structures like a vein or something, but sometimes because you just overextend the superficial facial system into which you are injecting your hyaluronic acid tissue filler. But then also obviously more severe complications can occur if you do not respect the limitations that the body gives to you. So we can end up with in the worst case, necrosis, because you're actually putting too much pressure on the subdermal plexus. So I'm 100% with Carmelo, respect the limitations of the body and rather have the patient in after, let's say, 4 to 6 weeks, see if there has been some pre-expansion, because every time you inject some MLF2, for example, you're expanding the matrix and you're giving a little bit more space for the next time. So always keep in mind that there is no cooking recipe, unfortunately, that we can give to you, but feel the skin, feel the turgor of the skin, as we say, feel the pressure of the skin and adapt accordingly. Also, obviously, in some parts of the world, this is a little bit more of a concern than in others, but in Spain, I do have budget-conscious patients as well. So spreading several treatment sessions over a couple of weeks, also from a financial point of view for the patient, is nothing bad, okay? Sometimes it probably even helps. And what is really nice is what we shouldn't forget, hyaluronic acid is a hydrophilic substance. So it also attracts a little bit of volume, and you see afterwards a little bit of a boost of volume. And based on the ultrasound investigation that we just did, I can tell you that most of the filler actually stays, but the volume expands a little bit more due to the hydrophilic properties of the HA. So 100% with Carmelo. Give it time, don't overdo things, and rather several stage procedures than one procedure that will cause any kind of complication in the long run.
Any kind of treatment with permanent filler?
I think so too.
Yeah, I would say that globally, a permanent filler, and guys, tell me if I'm wrong, but we are people from Colombia, from Europe. I'm European as well, but I live in Asia. The thing is, the permanent filler creates chronic inflammation. You can have an amazing result with permanent filler, which is stable. You don't destroy anything. It doesn't move. It stays there. And patients live with that with 10, 20, 30 years. Then you inject. And it happened to me with friends, guys, with friends and not with patients. It happened to me that I inject 10 ml of filler, just try to correct a small indentation, big inflammation with all the complications related to the permanent filler inflammation. So why we don't inject anything with permanent filler? Because we don't want to mix. Because permanent filler, it's permanent and it's active. So it can give inflammation, and the inflammation can cause complication if are not treated properly. Yeah, okay. Frank, you can answer really easily because I believe you have a lot of experience as well. What the things he said, and it's very true, the filler recalls water. There is a water attraction. So when we inject filler on the hands, the thing we want to do is to establish a nice moisturization of the skin. We can repeat the procedure 3 to 4 weeks after. That's why we can do in several sessions as well. We don't have to over-inject. Result can be stable, can be achieved even after 2 sessions. And this is because the hyaluronic acid works not only as volumization, but also as a rejuvenation of the skin and stimulation of the production of new hyaluronic acid itself. Constantine.
100% with you. And this is, I think, a really important concept that I think both of us share. Staging treatments is not a bad thing. And especially what you said, HA is not only a volumizer. We do have very good data on how HA actually kind of helps us to move from pre-adipocytes to adipocytes, how it helps us to reduce the lipolysis within adipocytes, which makes them more voluminous and bigger, and also throttles and reduces down the apoptosis of adipocytes. So injecting something and seeing what happens with the surrounding tissue is actually something I advise very much. And you can repeat the injection a second time, and sometimes you should even. I have patients coming in for 3 to 4 sessions, for example, for hip dip. I think hip dip is a really good example where you need to stage your procedures to kind of create some expansion, wait, create more expansion, wait, create more expansion. So this is my take on it. I do not feel the need to do a perfect correction in one go, but I rather also, as I said, patient management, give them a journey to their ideal buttock, to their ideal buttock shape, to their ideal hand shape, to their ideal calf shape. Give them a journey and set goals with them, because achieving the goal in the first time is sometimes really hard.
And
yes,
Luis, go.
Yeah, thank you so much. So 100% with all of you. And I want to just add something that is really, really important to have in mind. Every single patient has a different response. Every single patient has a different reaction. Anything, any medication, any procedures or whatever. We are as plastic surgeons, so we have a lot of experience in this. But it's completely necessary to know which are the expectations of our patients. So to know exactly what's the goal and what's the idea that we are going to proceed with the different treatment. So according to this, it's completely necessary to guide the treatment.
First, sorry.
No, please, Frank, please.
No, Luis, we kind of cut you out in the discussion before.
You
so
are
you
the expert.
Okay, so in my opinion, I think it's depending what's your field of knowledge and what are you expecting to do, right? So in my practice, I've been doing this for a long time with ultrasonography. So we use high frequency transducer. So we have more experience with this because we have remember that we need to use so low, more superficial and high frequency transducers.
This finished. Okay, perfect. I agree with you. I go between 7 to 12 megahertz. I think, to be honest, when you go into body indications with minimally invasive treatments, get an ultrasound. They're not super expensive these days anymore, and check. There is no need to check every injection that you're doing, but in the beginning, do a certain amount of self-control. And then obviously for me, a linear transducer somewhere between 7 to 12 megahertz does enough visualization of the depth that we need. You might be surprised, even in more obese patients, how thin the subcutaneous fatty tissue at the end of the day is. You might be surprised. It's not as thick as you might think. And I have to admit this, when I started checking my own injection results with an ultrasound, I had some patients where I actually injected below the deep fascia covering the gluteal muscle. And I would have been 100% certain that there would have been not a single way that I would have injected below the fascia. But it is surprisingly thin in some patients. So also do it a little bit of a self-control. 7 to 12 megahertz is for me a good rate. Do you agree with me, Luis, or would you go differently?
100% agree. And I want to add something. Now, as you said, we don't need to use for every injection the ultrasound, because we get used. At the end, it's nice to start to see exactly where you are. Then with the practice, the learning curve will come. But if you have to treat complication, if you will have complication, and guys, all of us, we have complication. We are not perfect. Everything can always happen. Ultrasound is a very important tool which allows you to treat the complication properly and being precise, because this is the thing. If you have a granuloma, if you have a lump, if you have a deformity, with the ultrasound, you know exactly where you're injecting. What Luis showed before, Dr. Reyes showed before, is the treatment of the between the retaining ligament of the lower gluteal fold on the lower trochanteric region. That area, if you don't know where you are with the cannula, it could be very painful for the patient. because you tend to be superficial, or you go under the ischiotibial plate, which allows the filler to slide towards the tendon, and you find the filler on the knees. And I'm telling you, I saw it. So it is very important, if you have the chance, to have a portable ultrasound. We don't need the 40 million dirhams, $40,000, sorry, ultrasound, but something that can help you with the practice, to build your practice and gives more awareness about what you're doing.
Exactly, and this, I think, the teaching moment that you can take from it helps a lot.
Yes, I have 16 on my office, and we have 20 at our operating room. So I agree with both of you guys.